My name is Ben Williams, and this is the MMPI2 Minnesota Multiphasic Personality Inventory 2 PowerPoint. The MMPI was developed in 1939 and was published in 1943. It was the main structured personality assessment until it was replaced by the MMPI2 in 1989. The manual for the MMPI2 describes it as a broad-based test to assess a number of the major patterns of personality and emotional disorders. The MMPI-A was also developed in 1992, and that's for adolescents. It's a similar assessment for kids aged 14 to 18. The main purpose of the MMPI2 and MMPI-A is to diagnose emotional disorders. However, it can also be used for non-diagnostic purposes. That means if you are a counselor and just want to talk to your client about what's going on with them and see things that maybe they can't figure out themselves or having a hard time putting words to, you can just use it as a tool, even if it's not used for diagnosis. The transition in 1989 from the MMPI to the MMPI2 was largely based on the group of people that were used to define the normal category in the assessment on the original MMPI. As the assessment was developed in Minnesota, it was largely white middle-class Minnesota residents that were setting the normal standard for the assessment in the 1930s. So as the country became more multicultural and more racially diverse, that posed a problem. The MMPI-2 used 1980 census data to include 2,600 individuals from different ethnic backgrounds in different parts of the country to base its normal standard on for the assessment. Now, there's still some controversy surrounding the people that were used for this because there are some reports that it was mostly highly educated people in high-status occupations around the country, which is not a good representation of anybody taking the assessment. However, it is known to be much more diverse than the original MMPI. The MMPI2 is accepted as the most widely used structured personality instrument by counselors in the field today. It's available in 4 languages and requires an 8th grade reading level to complete accurately. There is audio versions of it for clients that are not able to read at that level. The assessment has 567 items. The MMPI-A for adolescents has 478. They consist of statements such as, I am sure I got a raw deal from life, or I cry easily, for example. And clients indicate to all questions either true, false, or cannot say. The MMPI-2 was very widely researched between 1989, when it was created, and 2006, and I'm sure since then as well. However, between those dates, over 2,800 published journal articles came out regarding the MMPI-2. The MMPI-2 uses empirical criterion keying. What that means is items are selected based on their relationship to some external criterion, rather than the content themselves. So instead of just having a big questionnaire that says, do you feel anxious? Do you feel upset? Asking direct questions, it's asking questions to evaluate those criterion, such as do you find yourself worrying about your schedule on a daily basis, to evaluate if someone feels anxious. There are 7 to 10 validity scales that are used in the MMPI-2, depending on which ones you want to use. They're there to measure the degree to which someone may have attempted to skew their results. We'll get into that more later. There's also multiple clinical scales, which are subdivided into 3 major categories. 10 basic scales that are measured, 15 context scales, and other various special scales and sub-scales that were later developed. Basically, these clinical and basic scales are the meat and potatoes of the assessment. They're the content being measured. A T-score, or a score, of over 65 in any measurement in these basic scales is considered elevated. 60 to 65 is considered moderately elevated. So we'll start off by listing the validity scales, which are more or less used to make sure that the person taking the test is not trying to make their answers show them as one way specifically. You know, a client might be trying to put their best foot forward and appear like they're fine if they have mandated counseling or something, Or someone in a prison sentence might want to plead insanity, so they want to look deranged in their assessment. These validity scales are used to group together certain types of answers and test for those things and control for those things so we can make sure that the MMPI2 is an accurate, reliable, and valid assessment. So to start with the validity scales, the first one is the cannot say score. That just more or less assesses the number of items that weren't answered. If there's over 30 questions in the assessment that go unanswered, it usually invalidates the test as not enough information to make a valid assessment or have valid responses. Clinicians should verify, of course, understanding of the content and the questions with the clients to make sure they're not answering because they don't understand. And the cannot say score helps clinicians detect consistencies in the types of questions not answered. So if there's someone that doesn't answer all the questions about their home life, that could be something that needs to be looked further into. The VRIN, the Variable Response Inconsistency Scale. This more or less pairs together groups of similar questions. It tests these answers to assure that there's consistency within them, and it ensures that the test taker did not randomly pick answers. So there can't be 5 answers about home and one says you're great and love your home life and the other says it's terrible and you never want to go back. For instance, the TRIN, or True Response Inconsistency Scale, compares items that are marked true or false. It more or less just assures that people didn't randomly pick all true or all false or completely inconsistent answers on the true or false questions. The F, or Infrequency Scale, measures the likelihood that the test taker is either faking or attempting to exaggerate symptoms, so either positively or negatively. An elevated score indicates that they're either very blissful or very symptom-filled and upset, respectively. A score of 90 or above is considered to be atypical for the general population. Now, the infrequency back scale is different than a lot of the other validity scales because it specifically tests for the back end of the test. With so many questions in the assessment, it's used to make sure that test takers don't check out or start picking random answers or get bored during the last half of the test. It's used in conjunction with the F scale, also measuring items in frequency and frequency and making sure that they align with those items chosen by the general public in the last half of the test. The Psychopathology Infrequency Scale indicates rare or infrequent responses in a psychiatric setting. So this is kind of a special scale that's used mainly in inpatient mental health settings specifically to assess the validity of test takers in that environment. It compares answers with people that are typically in mental health settings to make sure that answers are consistent with that. The FBS, or Symptom Validity Scale. It's sometimes unofficially called the fake bad scale. It measures potentially exaggerated claims of disabilities or symptoms. So it helps to detect when test takers answer many well-being questions in one way, but answer questions about disabilities or symptoms in ways that don't typically match up with regard to positive well-being. What that means is, if a test taker answers a bunch of questions saying that they're happy and they're good and healthy, but their back always hurts, or something is always physically wrong with them or somehow disables them, it tests for basically the fake bad scale, the validity of their symptoms, if you will. Just 3 validity scales left. So the L scale, or the lie scale, provides insight as to what degree individuals may be trying to just look good with their assessment. And as the title suggests, it might not necessarily be a good indication of whether someone's a liar or tends to tell the truth all the time. It's used more to indicate whether clients are trying to appear overly correct or over politically correct or socially correct and answer the way they think that they should answer on the assessment. Now, the K scale, or the correctness scale, like the L scale, measures positivity, clients representing themselves in an overly positive manner. But this one specifically measures for defensiveness or guardedness. Client motivation is really important to consider within this, and of course all other validity scales, but they could just be being guarded or defensive because they're anxious test takers or they're seeing these questions laid out right in front of them. So these things need to be decided, of course, before figuring out if the MMPI2 is the right assessment for your client. The last validity scale is the S, or superlative, not sure how to say that word, self-presentation scale. So it also measures defensiveness, but it goes deeper. because it seeks to discover reasons behind the defensiveness using subscales. This is helpful in interpreting defensiveness and if it will skew the results. The subscales are belief in human goodness, serenity, contentment with life, patience and denial of irritability or anger, and denial of moral flaws. Moving on to the basic or clinical scales in the MMPI2, they're the main scales that are interpreted for emotional disturbances or whatever a clinician may be looking for using the MMPI2. They should never be interpreted in isolation. They need to be interpreted in the context that the MMPI2 is being conducted in, and with the analysis of the validity scales and what may have come up during those. Also, many clinicians only focus on the scales that return with elevated or moderately elevated results. That is, T-scores over 65 or in the 60 to 65 range. But scales with non-elevated results can also be helpful because it can assess strengths, coping skills, etc. if a client scores, really well on certain things that could help them cope with things they might not score so well on. So that can be of use as well. The first basic or clinical scale, Scale 1, is hypochondriasis. This measures the excessive concern of a client with their health. It's measured by reported concern with bodily complaints under the assumption that a client is generally in good health, yet has excessive complaints about their body or their health in general. Scale 2 is the depression scale. It measures client reports of sadness and depressed feelings. Elevated scores suggest feelings of discouragement, hopelessness, and isolation. So Scale 2 basically tests for depression amongst clients, or depressive feelings if we're not looking for a diagnosis. Scale 3 is conversion hysteria. This concerns disorders that combine denial with a complex mix of that and social flamboyancy. Basically, elevation in this scale suggests superficial tendencies, attention-seeking behaviors, lack of awareness of the client's motivations, and also a lack of awareness of the motivations of others. The next scale, Scale 4, is psychopathic deviant. Elevation in this scale suggests that a client is struggling with an issue but can't or won't identify a conflict that is causing that issue. Those with elevated scores in Scale 4 often show hostility or a sense of being jaded toward the world. They often blame others for their problems and don't take any responsibility themselves. Those with very high scores in Scale 4 often have a really hard time finding change as a result of counseling. Scale 5 is an interesting one. It's the masculinity-femininity scale. So it measures whether a client's emotions, interests, desires, perspectives, attitudes, all that kind of stuff generally correlates with those that are typical for other people in their gender. So no matter what your gender is, an elevated score means that a client's views of the world and all the things that I just mentioned deviate from those seen as normal for other test takers of their gender. Kind of interesting one in today's world. Scale 6 is the paranoia scale. So just like it would imply, Scale 6 measures patterns of suspiciousness, mistrust, delusional beliefs, and extreme interpersonal sensitivities, basically paranoia. It can also imply self-centeredness or big insecurities. An elevation indicates a likely misinterpretation of others' motives or intentions. Basically, a client thinking that everybody is out to get them or that other people's intentions directly have a negative impact on or a negative desire to impact their lives. Scale 7 is called the psychasthenia. It is related to anxiety and obsessive compulsive disorders. So it measures neuroses, anxiety, distress, that kind of thing. Big stressors. Moderate scores in Scale 7 can actually indicate maybe some mild neuroses, but being organized, punctual, perhaps a little neurotic about these things, but still very functional. However, elevated scores indicate overwhelming anxiety and neuroses surrounding these things, so things that do lead to big social anxieties and obsessive compulsive disorders. Scale 8 is a schizophrenia scale. So questions might seem odd to a majority of clients. They might seem kind of out there. They surround unusual beliefs and experiences. And if clients have experienced those. Elevation indicates non-conventional lifestyles, potential isolation, alienation from other members of society, and extreme elevation does indicate latent psychotic symptoms. Scale 9 is hypomania, one of my favorite things to study. Hypomania in this scale surrounds being energetic, hyperactive, and euphoric at times. Elevation in this scale indicates frequent overstimulation, overactivity, being kind of flighty, jittery, overexcited, and overly emotional on either end of the scale. Now, those with elevated scores on scale 9 can easily fluctuate between euphoria and irritability very quickly. The last basic or clinical scale in the MMPI2 is scale 0, social introversion. Now, we all know social introversion is not necessarily a terrible thing. Some people are just more introverted than others, and it can be completely healthy. However, scale 0 measures how much a client enjoys not being in the company of others and social isolation. Elevation does indicate always wanting to be alone, but like I said, that's not always bad. It depends on the contexts. Frequently, therapists do associate high levels of this and wanting to be alone is bad, but it can be healthy. Very low scores on the complete opposite end on scale 0 can indicate attention-seeking behaviors, impulsivity, and self-indulgence, kind of an immaturity as well. So moving on to further interpretations and uses of the results that come from the MMPI2, there are 2 and 3-point codes that pair commonly elevated scores together, and some clinicians and other professionals that use the MMPI2 do use these codes. It assists with interpretation and grouping of the results. It's not recommended for the MMPI-A for adolescents, but it can group together certain things and certain commonalities that come from the MMPI2 and kind of give a clinician an area of where to look for issues that clients may be having. There are also many other supplemental scales to assist with the interpretation of results in the MMPI2. Many have been developed over the years. Most are used to test for certain pathologies or certain tendencies, social anxieties or addiction issues. Most of these subscales and supplemental scales are used to specifically figure out one thing. Now, as I said before, and we'll keep saying, counselors must have really in-depth knowledge of this assessment, their client, the context, the whole big picture in order to correctly interpret results, because it's really easy to misinterpret results on such a big, broad test. Content scales are something that therapists and other people that are conducting the MMPI2 will often use. They group results into several generalized categories of concern based on the results that come from the basic or clinical scales. It's a widely used, probably the most widely used supplemental scale, and there are several current ones. They even have acronyms. They are anxiety, fear, obsessiveness, depression, health concerns, bizarre mentation, anger, cynicism, antisocial practices, type A personality, low self-esteem, social discomfort, family problems, work interference, and negative treatment indicators. So that kind of groups answers and results into things that may be within a category that a client is struggling with and helps a therapist know really where to go after interpreting results of the MMPI2. Interpretation is such a big deal with this assessment. I keep touching on it. It's very specific and very complex for the MMPI2. Training is really needed to correctly interpret results. There has to be a close consideration of context that the test is being taken in, whether it's a counseling office or a job or a mandated client or group therapy. So much consideration needs to be taken into that, and the results need to be looked at from that perspective or that lens. There's lots of data, to look at. The validity scale should be interpreted, and then the basic or clinical scales within the data and through the scope of the validity scales, so a counselor can really understand the whole picture of what the assessment is showing instead of just basic statistical results. Multicultural considerations. So like I said, the original MMPI was mainly just assumingly white Minnesota residents in the 1930s. In the 1980s, they did get a more diverse group, but the MMPI2 is still criticized for having a sample of mainly highly educated and people with good jobs. So Multicultural considerations are really important to be taken, into account when someone's administering the MMPI2. Anybody can take the assessment. Results just need to be interpreted according to the context of the client's culture and life. Any clinician using the MMPI2 on diverse clients, racially or otherwise, should use careful consideration in interpreting the normal results that the scale produces. A client's culture could differ greatly from the majority of Americans that were used to create the normal sample. In certain cases, differing from that might not mean psychopathology. So it's generally a good assessment to use across racial and cultural lines because it's so thorough and tests things that all humans really do struggle with. But the key is a careful and responsible interpretation. Validity and reliability. So it's such a widely used scale with so many things to control for potential issues that validity and reliability are generally strong with the MMPI2. I mean, just having a whole scale to control for validity is something that not a lot of assessments have. So that, it is a very valid and reliable scale, all things considered and relatively speaking. It all boils down to interpretation and clinician responsibility for how the results are used, as I've said over and over. If a client presents with a particular concern, certain sections or subsets or subscales of the MMPI2 can indeed be very useful. Ethics are always a big deal in counseling, and it's no different for assessments in the MMPI2. It's very easy to misinterpret information rather. It's such a broad scale that it's very easy to do. It's important to always act in an ethical manner and adhere to, of course, the first ethical principle of counseling: first, do no harm. There's so many different ways that information from the MMPI2, having over 500 items, could be interpreted. Clinicians must really be careful to not be looking for potential results that they think they're going to see, because there'd probably be a way they could figure out a way to see them with so many items being tested. The MMPI2 has been updated and restructured in an attempt to keep up with the changing world. We're not in the 1930s or 1940s anymore. New subgroups and supplemental scales are always being created, and that's what's pretty cool. Because even within the base questions from the 1989 scale, different subgroups and supplemental scales are being created to test for things that maybe weren't around then. So that's important. But the world has changed a lot in the last, 27, 26 years. So another scale might be prudent sooner rather than later. So my recommendations surrounding the MMPI2 is, as I've said, interpretation of the MMPI2 results. They must be done responsibly, and advice must be only given based on the most solid result profiles and things that have been tested and controlled for. As with any assessment, they should be used, in my opinion, to provide insight into client tendencies, beliefs, actions, attitudes, not necessarily to pull out a label or a diagnosis for a client. So that concludes my presentation on the MMPI2. It's a very thoroughly tested, strong, structured personality assessment. With proper training and understanding, clinicians can really use it to gain valuable insight into a client's lives, often in ways that a client may not be able to articulate right away, if ever. However, responsible interpretation, multicultural, and ethical considerations are, as always, of the utmost importance when using the MMPI2 or any other assessment. Thanks.